Welcome to our group presentation for Exploring Mental Health and Developmental Disabilities by Carlos, Natalie, Amanda, Eugene, and Grace. We have chosen to research an anxiety disorder called Selective Mutism. Enjoy. Let's begin by talking about what selective mutism is. According to the DSM-5, selective mutism is defined as a consistent failure to speak in social situations in which there is an expectation to speak, like in school, even though the individual speaks normally in other situations.
In this slide, we will talk about some of the defining characteristics of selective mutism and how it affects those afflicted. Selective mutism tends to develop around the preschool years. In order for a child to be diagnosed with selective mutism, there must be a consistent failure to speak in social situations where speaking is expected despite speaking in other situations. Other situations may include more comfortable environments such as being at home or what they deem to be a safe space. Another requirement for selective mutism is the duration of the disturbance. It must be at least 1 month. This month, however, cannot be the first month of school, as other factors may influence the child's shy temperament when exposed to a new environment. Individuals who are in an environment where their first language isn't used may not qualify for selective mutism. The individual may also show symptoms of other anxiety disorders. Individuals reported feeling physical symptoms of anxiety such as shaking, sweating, and increase in heart rate. Experiences such as these may lead to individuals displaying symptoms from other anxiety disorders, such as social phobia, wanting to avoid the panic-like symptoms they fear and avoid the triggering situations altogether. Selective mutism, when chronic, may lead to poor academic performance, poor social skills, and peer rejection. Young adults who were diagnosed with selective mutism as children have reported difficulties with self-confidence, independence, achievement, and social communications.
The significance of selective mutism. There is a low prevalence rate for selective mutism, as it is not very common in the population. Studies have shown the prevalence of selective mutism to be anywhere from 0.11% up to 2%. It's suspected that there are higher rates in children that go unreported. Genetics, environment, and temperament all contribute to the onset and maintenance of selective mutism. In a study called Adolescent Social Anxiety as an Outcome of Inhibited Temperament in Childhood, children who were classified as shy, apprehensive, and withdrawn at age 21 and 31 months were 61% more likely to have a social phobia by age 13 compared to those who were not. Selective mutism is often present with a variety of comorbidities or other mental illnesses. These include obsessive-compulsive disorder, depression, premorbid speech and language abnormalities, developmental delay, and even some types of autism. Other studies show high comorbidity rates with other anxiety disorders, including agoraphobia, generalized anxiety disorder, separation anxiety disorder, panic disorder, and post-traumatic stress disorder. 97 to 100% of children with selective mutism also have a social phobia diagnosis, and almost 18% of adults with anxiety meet the criteria for a substance use disorder.
My name is Eugene, and I'll be going over the treatment and intervention for selective mutism. So the treatment of selective mutism has always been difficult to do, as there are many approaches as how you can treat selective mutism, including behavioral techniques, psychodynamic approaches, family therapy, and pharmacology. In contrary to popular belief that children with selective mutism will eventually grow out of it, and that this condition will improve with age. This is not the case, and without proper treatment, it can lead to depression, anxiety, and other mental health issues. Behavioral techniques is the most used form of treatment for those afflicted, and is based on principles of learning theory. Mutism is suggested to be a learned behavior. Techniques such as reinforcement, stimulus fading could be used, for example, to get rid of reinforcement for mutism. By doing this, it can increase self-confidence and decrease anxiety. A study done by Calhoun and Koenig in 1973 showed that there was a vocalization after 5 weeks after providing peer and teacher support. Although there was an improvement, it plateaued and it was not significant after a year. Other techniques such as stimulus fading, where therapists set simple goals and gradually increase the difficulty of social interaction. In addition, shaping, where the mouth movements were reinforced until true speech was achieved. In using psychodynamics, those who used this therapy suggested that the patient had underlying conflicts and tried to resolve them by using therapy sessions. This often took a lengthy amount of time, as the patient was not always open to speak, if at all. The use of play and art helped to facilitate the communication. In family therapy, it was suggested that the family the child is in is the causal factor in the development of selective mutism, and the interaction with family during therapy seemed to encourage this mutism. This was found not to be effective when it came to treatment. Although it was not a sound therapy, it instead included family members in the design of other treatment plans, which seemed to be more effective. In pharmacotherapy, pharmaceuticals such as selective serotonin reuptake inhibitors were shown to help with social phobia. In 1990, Goldwyn and Weinstock described a 7-year-old girl with mutism who responded to phenelzine. She had progressed from not speaking a word to talking freely to teachers and peers. Black and Udd used fluoxetine in 1992 with another girl, 12 years of age, who had elective mutism and had improved greatly after taking this, also speaking freely to teachers and students. Black and Udd later on completed a 12-week study on 6 children taking fluoxetine and concluded that there was an improvement. There were some areas of mutism and anxiety that did not show positive changes. Researchers have suggested longer trials to see the effects of other drugs that would have on children with selective mutism. Speech therapy focuses on helping children with articulation and language, and avoided discussing the mutism and the child's feelings. Once the speech was corrected, Smaling in 1959 found that 5 of the 6 children started to speak in school, and Straight in 1958 used speech therapy along with behavior modification, and this cross-therapy showed improvements as well. Children can definitely benefit in practicing structured language. The school-based multidisciplinary individualized treatment plan is used in the school environment, collaborating with teachers, parents, and clinicians to decrease anxiety associated with speaking and encouraging the child to communicate. This is started in the classroom, where a teacher might split the class into smaller sections and find supporting peers. The use of card system or gestures to communicate basic needs, as well as using speech therapy to help the child avoid talking in a way they find is awkward, which will in turn increase their confidence and communication.
Selective mutism is a condition that is considered hard to treat, perhaps because it can be hard to identify its exact etiology. As mentioned by Eugene, many treatment options are available, but the most commonly used method is behavioral therapy. In particular, cognitive behavioral therapy, or CBT, is a highly recommended approach for individuals with selective mutism, or SM. We'll now look at a 2015 article by Oerbeck and colleagues that studies the effect that CBT has on outcomes in children with SM. Overall, behavioral therapy uses behavioral techniques based on the learning theory to intervene and cause change in undesired behaviors like those seen in SM. As it sounds, there's a cognitive and a behavioral aspect to CBT. However, in other studies, as well as the present study, the behavioral aspect of CBT has been heightened over the cognitive aspect due to the early age of onset seen in children with SM. Often, it's before the age of 5. This study used CBT in a school-based intervention because the authors found that SM symptoms tend to affect and limit children the most in school settings. Some of the behavioral interventions that will be discussed are defocused communication and stimulus fading. These will be expanded upon in later slides. Now we'll explore the methods used in the study. As you can see, there were 24 children chosen between the ages of 3 and 9 years old, and they all had selective mutism based on diagnostic criteria from the DSM-4. Of these children, 6 of them were bilingual. The majority of the children in the study came from families with a history of SM, or the parents suffered from some sort of social anxiety in their own childhoods. For the bilingual children, the mutism was present in their native language. Some of the exclusion criteria ensured that the children who were on medications for their SM were not participants so that the full effects of CBT could be assessed without alternative influence. In order to be included in the study, the children were found to not be able to speak to adults at all in their school environments. Overall, the children spent 6 months doing cognitive behavioral therapy with a therapist. The first 3 sessions were actually at home, and this served the purpose of developing a relationship between the therapist and child in a familiar and safe environment. This also allowed for increased parental involvement at the start of the sessions. These sessions would be the building blocks for the future school sessions. While at the homes, the therapist used defocused communication, meaning that they sat beside instead of across from the child, or they got the child to simply share their thoughts out loud rather than asking them direct questions, or the therapist would be optimistic and continue to talk even if the child didn't answer. This defocused communication helped reduce social anxiety for the child. The remainder of the treatments occurred in the school setting, still adopting this defocused communication approach, but eventually increasing the child's exposure to avoided or feared situations where speech was expected. Here, behavioral interventions took place 2 times a week for half-an-hour blocks, and they were followed by 6 modules involving speaking to the teachers, to therapists, all with or without the parents present. These behavioral interventions involved stimulus fading, where the children would be increasingly exposed to speaking situations during an enjoyable play activity. The children were assessed at 4 different points of the intervention. As you can see, the baseline before the study started was called T1. 3 months after the study ended was T2. 6 months after was T3. And 1 year post-therapy treatments was T4. Questionnaires were used for the main outcome measures. The SSQ, or School Speech Questionnaire, was based on the amount of speech that the child used in the school setting, and the rating was completed by the teacher. The SSQ includes 10 questions, where each question was scored either a 0 for no speaking all the way up until 3 for always speaking. The internal consistency of this questionnaire was considered acceptable. Similarly, the SMQ, or Selective Mutism Questionnaire, had acceptable internal consistency and was scored in the same way, but it had 32 questions. This time, the mothers of the participants rated this questionnaire so that the therapist could have an honest idea of the child's progress at home and in public outside of school. The scores from the 2 questionnaires both showed that CBT effectively led to significant speech increases in the home, in schools, and in public for the majority of the children. The greatest improvements were seen between the time of T1 and T2. Amazingly, at the end of the study, 12 of the children could no longer be classified as having SM according to the requirements in the DSM-4. They now spoke openly at school. 4 more children began to speak openly in the school only sometimes, and they were classified as having SM in remission. The final 8 children still had SM at the study conclusion. Of the children who were 3 to 5 years old, 78% of them no longer were classified as having SM. This was compared to the 6 to 9-year-old group, where 33% of them were classified as no longer having SM. Knowing that SM usually appears in children before the age of 5, and that younger children are shown to improve more after CBT, it is crucial to begin treatment early on. The level of significance found in the study, where P was less than 0.05, showed that CBT is an effective form of therapy that decreases SM symptoms in children ages 3 to 9. Although some of the children were still classified as having SM at the end of the study, all of the children showed a significant increase in speech. Many other researcher articles that I found focused on only 1 child with SM in a case study, but this doesn't really give us results that can be generalized. A general rule of statistics is to have over 30 participants in your sample in order to have statistically significant results. But, compared to what is out there in the literature to date, this study has a reasonably large sample size with 24 participants. Importantly, this study showed that CBT with a school-based intervention was an effective method for eliminating the diagnostic criteria for SM in half of the children. On top of that, these weren't short-term effects. Even at 1 year of follow-up, the desired treatment outcomes remained. On a personal note, I liked how the study included bilingual children. Remember that the bilingual children were selectively mute in their native languages. This means that the children weren't selectively mute with their second language because they didn't know it that well. Rather, there must have been some other reason why the child was mute in their first language. This helps us to understand that there can be many factors and etiologies behind why this SM condition presents itself. A negative critique I have for this study is that the therapists performing the CBT did not have previous experience in this field of therapy, and perhaps their expertise in this area could have led to more children having no SM at the end of the study. Knowing all of these results, there are a few further steps that can be taken in the research field. For example, how does this same CBT approach with a school-based intervention affect children over the age of 9? Are less desirable outcomes achieved because the children are past their younger prime years for treating SM? Or, how do participants change and respond when CBT is paired with other treatment methods that have also been shown to be effective, like pharmacotherapy?
The portrayal of selective mutism in the media.
While searching for selective mutism in the media, we found that there were 5 pieces of media that were in English that were available to us that were specifically centered around selective mutism. The first is in movies. There are 2 short films centered around selective mutism. The first one is Yoshi, which is released in 2016, where the main character struggles with selective mutism. The illness is not a main point of the plot, but it's simply added a fact of life for the main character. The second short film was released in 2012 called Demi Point. The main character here struggles with selective mutism, and in this short film, the illness is sought to be overcome. The second form of media where we found selective mutism was in books. The first is called The Weight of Silence in 2009, which centers around a toddler who has selective mutism and is kidnapped. The second novel we found was Persona Medusa, which was released in 2016. It's a narrative biography of the life events of the author, which surround the illness of selective mutism. It can be also considered a memoir. Finally, we found a piece of art by Toby Allen from a series he did called Real Monsters that was first published in September 2013. He describes his series as an ongoing personal project exploring mental health through character design. The project aims to reduce the stigma surrounding mental illness and aims to educate about the lesser known conditions. Of the media we found, Persona Medusa was one of the more interesting pieces. After doing some research, we found that it had almost a full 5 stars on Goodreads, and I've put the synopsis there for you to read. It's not as well known, but it's definitely a recommended read if you want to learn more about selective mutism. I was unable to read it and thought it would, but if I had time to read it, I thought it would be a good choice for this assignment. But that being said, I would not have been able to give an accurate reflection of what this novel entails and its accuracy regarding selective mutism. So this is just to show you that there is literature out there or media out there that could be more influential than what we're going to cover today. But today we will look at something different. For this assignment, we decided to cover specifically Toby Allen's Real Monsters version of selective mutism. The image for selective mutism was actually published in 2014, and the little blurb that's in the image I've copied over so it's more legible for you to read just to the side of the image. And we chose it because it's a semi-popular piece of work, but with it being art, it's also open to interpretation, which is helpful for talking about the accuracy in the portrayal of selective mutism. First, we wanted to answer the question of, does art have influence? That being said, this particular piece of art, I would say, does have influence because it has been published not only on websites such as Tumblr, Facebook, and Imgur, but also in more formal publications such as the Broken Grey Wires exhibit, Anxiety UK, and TWLOHA and NAMI. This image could have a negative influence on how people perceive selective mutism, mostly because of the title of the series in and of itself. Monster implies that it is something to be feared and it's negative in nature. The creature in and of itself can be perceived as unnerving, and so therefore the illness might be perceived as being unnerving or unnatural. The positive influence that this piece of art would have is that in the description it does state that it affects both children and adults, and that it is possible to manage the illness. In terms of accuracy, I would say that this piece of artwork does have some accuracy to it. For some who struggle with mental illness, it can feel like living with a monster. The illness does affect mostly children, but can also affect adults. And the monster that is described in this image has a kind of selective mutism of their own, where they're stealing the voice of a human so that they can speak in their own community. So it shows almost for them what suffering with selective mutism might look like. There are some ways that this image is not accurate. For one, it only covers the cardinal aspects of the illness, but it also does not include common comorbid conditions and struggles, such as social phobias, other anxiety disorders, or potential substance abuse. This piece of art also doesn't really depict what living with the illness is like for a human being. It only gives a shape of something to blame for selective mutism. And it's not, but at the same time, accuracy is not or could not necessarily be the author's goal. Overall, I would say the selective mutism piece as part of the series called Real Monsters by Toby Allen does have a positive influence because it promotes the idea that selective mutism is manageable, and it seeks to educate and to bring awareness to selective mutism. In terms of accuracy, I would say for the sake of awareness, it is accurate. It's talking about the broad idea of what selective mutism is and what that looks like for other people, so that it spurs the onlooker of this piece of art on to learning more about selective mutism and what that looks like for a human being.
In conclusion, individuals diagnosed with selective mutism can face a variety of challenges. As with any type of anxiety, each person is affected differently. For some, it may be challenging to form and maintain meaningful relationships or perform activities of daily living, like speaking to others. As we've discussed in Module 5, there is a strong need for support and acceptance of people living with any type of mental illness. It is important for healthcare providers and future healthcare providers like ourselves to work on a case-to-case basis to ensure the right supports and treatments are put in place for individuals living with selective mutism or anxiety. Thank you for listening to our presentation.